welcome to today's episode of Injury Prevention for Runners. I'm Dr. Kevin Christie, and I'm going to introduce you to Dr. Borzykowski. He is a radiologist, and we're going to discuss a lot of the imaging concerns that our runners and triathletes have. And so today we're going to focus on three key topics. There's obviously many more than this, but really what path you need to go down to rule in or rule out stress fractures or stress reactions. The second thing we're going to discuss is muscular strain in imaging and figuring out what the severity of that is. And then the third, we'll talk about lumbar disc issues. We see a lot of that in runners. We see a lot of that in our desk workers that are also runners. So it's definitely something we see a lot in our practice, and I know you see a lot. So introduce yourself a little bit, what you have going on, and then we'll go from there.
Thank you, Kevin. I appreciate you having me on here. I'm Borzykowski. I'm a radiologist who specializes in musculoskeletal and orthopedic injuries. Especially, and work here locally in Boca as well as Palm Beach County. I have offices, so I appreciate having you on here. I've worked closely with you, seeing your patients and trying to provide good care for them.
Yeah, absolutely. You know, we had met, it's probably been 6 or 7 years ago now because of the NFL Combine stuff we do, and we needed a trusted radiologist for stuff that we see coming in or that happens during their training, and so it's always been nice to have that referral source. I can text you on different things, and so if it gets complicated, I know where I need to send for that.
Yeah, in my previous job I was a radiologist for the New York Jets, so I had some experience obviously with the NFL and currently with college players a lot as well. So
all right, yeah, so let's dive right in. We're going to start right with the stress reaction. I know in my clinical practice I see a lot of lower leg injuries. I know you can get stress reactions kind of all over depending on different sports and different stresses, but obviously with runners it's a huge concern, the foot and ankle all the way up probably into the leg, and there's always this concern as to when to get the imaging, if it's going to show up, things like that. What would you say from an imaging standpoint are the best practices when you're dealing with a runner that's running high mileage and potentially has some kind of stress reaction to the bone?
Sure. So, when this kind of injury occurs, the person will often go see their clinician, whoever they see for that, and depending on the circumstance and how high the suspicion they have of an injury, often depending on in the office, someone might start with an x-ray, sort of the low cost, but unfortunately low yield a lot of time with these stress injuries in terms of finding it. But if a fracture shows up, it's easy to stop there and kind of know what's going on. But unfortunately, most of the time, these injuries are going to be occult and radiographically occult, not seen on x-ray, and sort of then have to either progress to the next form of imaging, and MRI is the sort of next recommended study for that.
Okay, that's kind of what I've always gone by. Is there a time frame? Let's say person gets injured yesterday, no traumatic cause, just all of a sudden they have pain, somewhere. How long should they wait to potentially get the x-ray to at least, like you say, that's the low-hanging fruit, it's inexpensive, it's easy to do. When should they do that for?
Yeah, I mean, obviously there's no set-in-stone time frame. I think, barring a traumatic injury or hearing a pop or something that seems a little more aggressive occurring, if someone's your typical everyday runner, has been feeling, today they feel something a little more in the leg. I don't think imaging right away is necessarily needed in that scenario. I get that. I do a lot of exercise. Often those things might go away. But if the kind of person putting on a lot of miles and repetitively doing this, start to feel it over a couple of days, then a week, and it's kind of lingering and staying there. It's now been 2 weeks. First obviously trial of some rest and seeing how that goes, but I think that's sort of in the range as you get a couple weeks out is when people start wanting to at least see what's going on to then help figure out how much rest time is needed from there.
That makes a lot of sense. And that's a key distinction, is that we're talking about overuse. We're not necessarily talking about trauma.
Correct.
If something happens traumatically, that's a whole other level, which we won't get into. But then the person gets the x-ray, and let's say, obviously if it shows up on x-ray, we know what we have.
Correct.
Which is a great thing to be able to, like you said, start from the basics and go from there. Now, let's say the symptoms continue, the x-ray was negative or clean. When should they potentially, I know a lot of this is based on clinical judgment of the practitioner, but what are you seeing typically as far as, should they get an MRI right away, or should they wait a little bit more?
Yeah, and I often, just because as the radiologist we see from the referrers, we see the time frame of injury, our techs note down the time frame, and I think, rarely do you see leg pain one day, 2 days, usually on an MRI request, especially in an overuse person, at least in terms of running. I think is when you start getting over 4 weeks, things like that. People say running on and off, intermittent pain in the leg every time I run, things like that. If the pain is severe, people usually come in earlier and get imaged earlier. If the pain is sort of that I can deal with it, but every time I run, but otherwise it doesn't hurt, people wait a little longer. And I think today, luckily an MRI has no radiation, really no negatives to doing it. So I think, knowledge provides a lot of information going forward and rules out other causes that might not be related to the running. I think that's an important caveat.
Yeah, and I think that's a good topic to discuss because there's a lot of people concerned about getting an MRI, and we don't need to discuss the finances of an MRI because insurance, that could be a whole episode. Right. But as far as from a safety perspective, what would you have to say?
Yeah, MRI, like I said, there's no radiation associated with MRI. In terms of compatibility, people with certain pacemakers and things like that, some are compatible, some are not. Orthopedic hardware in the body typically is fine to get an MRI. People always think if there's metal, I can't have one. Even if there's metal in the area, there may be some artifact which may limit the study, but we have specialized sequences we use nowadays that we can remove the artifact and be able to see more. So really, it's a really safe, reliable, and accurate test.
Yeah, it seems like it's not like it was 20 years ago.
No, and it's quick. An MRI of let's say for the lower leg, you can do in 20 minutes, 20 to 30 minutes. So it's not, being in the MRI machine for a long time, especially the MRIs nowadays, a lot of them are relatively open. Even the ones that are high field and are not called open are still much more open than they used to be. And you might go with just your legs, so your body's out. Okay. So it's not something that's completely uncomfortable. So, someone being claustrophobic shouldn't be a contraindication to giving it a try.
Perfect. A lot of our runners tend to be very analytical, attention to detail oriented and stuff like that. So some will definitely appreciate this. When you see now that person comes in, they have the MRI, and there are positive findings within the bone, what are some of the things that you're looking for and you're seeing on that?
Yeah, so for us, we kind of look at this as a spectrum of medial tibial stress syndrome. And that spectrum can be things that are very mild, where there's just some mild edema along the anterior or posterior aspect of the bone, a little periosteal edema we call it. That's sort of the most mild form that we'll see, sort of a very early grade. And sort of these grading system, and there's a whole system of Fredrickson classification that they use in MRI. We don't need to get into details of that, but these systems help the referring clinician, whoever sent them there, sort of figure out maybe the time frame of how long they should be out of the activity. Nothing set in stone, but helps sort of guide the time. So you might have some mild edema, you might have some actual changes in the bone itself, sort of the next level, some mild bone edema. We can see some changes in the bone in terms of the bone canal or the cortex, which is the periphery of the bone. And then we sort of grade up we actually see changes in the bone, we see changes in the cortex, we actually see a fracture line, and that's sort of the end stage. So a lot of times people say, and we'll see this on feet too, I have a stress reaction, stress fracture. Unless there's an actual fracture line, we don't usually use the word, most radiologists stress fracture, but we'll use it whether it be the stress reaction. And then to grade how much edema there is, any soft tissue changes and things like that.
And that's a key distinction, is that there is a difference between a stress reaction and a stress fracture. And I think sometimes
there's a difference on imaging, and the clinician may lump them together when they present it to you, like you have a stress fracture, even though there was severe reaction. And differentiating is really more important in determining how long you should be out of the activity and related to how we should follow it on healing than it is more getting into the semantics of the...
Exactly, and obviously there's always that communication between the clinical treating physician and yourself.
Correct.
To where that needs to be conveyed to someone like myself, so then we can then convey that information with all the other information that we have on history, consultation, exam, and then develop a game plan of the treatment and obviously the time frame away from running. And the difference between a stress reaction that's really mild and a full-blown stress fracture is going to be different.
Very different.
Absolutely. So, and I think that really kind of covers, obviously we could do a whole hour just on
I could talk about this for a long time.
But I think that really it gives you the understanding of the differences between stress reaction, stress fracture, how the path to figure out what the actual answer is, and the importance of that path. It goes without saying, is it's really going to be, if you have a race coming up in 6 weeks, we need to know if there's any type of stress reaction at all, or if it's not, or if it's fracture, or if it's reaction. So it's important to go down that path if the clinical symptoms aren't getting better and there's other types of
especially, Kevin, the important thing also is you not only see the bone, but you see the soft tissues, the muscles, and everything else around, so you can rule out other conditions and other findings as well, which is helpful.
Which is a perfect segue to the next topic, which we're going to discuss, because obviously a vast majority of our overuse injuries with running tends to be muscle, tendon, ligament, and so we lump that into something just we call soft tissue. It's the easiest way for us to differentiate the bone, which would be more hard tissue, right? So we get this a lot as far as muscle strains, because we can grade muscle strains from grade 1, 2, and 3. Same with ankle sprains and things of that nature. We see a lot of. Obviously, with an ankle sprain, going to be a lot more traumatic causes of it, but there's obviously overuse conditions that can affect the ligaments and tendons. But let's focus today on the muscles, and when we're dealing with something that's not getting better. And then honestly, I see this a lot. If someone has an event or a sport where they actually do need a time frame to know when they can do something. And I see this a lot with my football guys. Like, look, I need my hamstring MRI because I need to know exactly what the level of strain is, because that can be, is it week 1 or is it week 4 they come back? And so on imaging, what are modality, or I guess it's MRI, you're using MRI, and then what are you looking for as far as muscle tissue?
Right, yeah, MRI is the most sensitive and specific study for that, especially when you really want to get into the details that you set for your high-level athletes and relating to whether that extra week or how much timing is important to what's going on. And I think, like you were saying, the important things that we're looking at is we're sort of grading things, and that grading is helping whoever the treating physician is determine how long they should be out. And I think we were talking about lower leg is where we were talking about. So people might have a pain in their calf, or they've had, subtle mild pain that continues on. But a lot of times calf injuries, especially, people have a more acute, whether I feel a pop, they're running, something like that. And I think those ones typically get imaged much more immediately on MRI.
Absolutely.
And I think what we look for on those, and sort of the more common injuries that you get there, let's say you're running, you feel a pop in your calf, or you're doing a jump or a box jump or something like that, something basketball related. I think then really we're looking at, two main injuries are either medial gastrocnemius, which is calf muscle, strains, tears relating to the muscle, the surrounding fascia, the Achilles tendon itself, which is the distal aspect of those muscles, or a plantaris rupture, which is sort of used to be called tennis leg was the term for these things. Plantaris muscle, not a muscle you really need, but the rupture of that tendon can cause a lot of pain, hemorrhage, things like that. Nowadays, more often than not, the cases are medial gastrocnemius, not plantaris. So we basically look at it and we're going to tell you how bad the tear is. Meaning, is there some mild edema, mild strain? Is there more edema, more moderate grade strain with tearing of the muscle itself, partial tearing, high grade tearing, full thickness tearing? And then is there a hematoma? Because the hematoma might cause a lot of the problem, which is a blood clot sitting there. Blood basically accumulates from the tear, and that might be hard to, having that there might increase the time it takes to get back.
Yeah, it makes sense. And again, the good thing too is while you're in there, you are also potentially ruling out the bone stuff.
Absolutely. At the same time, we see all of that.
You're getting that full picture. A lot of times I'll assess someone, and I can kind of tell if it's a low-level strain or not, and then based on all kinds of other clinical findings, say, okay, we can treat this. But then if we start hitting our head against the wall, we're not getting the results, we may need to get that advanced imaging. Or like you said, if it's pretty, like someone shot you in the back of the calf while you're running and it pops or something like that, might be a good.
And I think those are the two scenarios we mostly see. An acute injury where it's something that feels more significant acutely, image, and then the other ones is not responding to treatment. Because a lot of times what's going on clinically, the referring doctor, you examine the patient and you kind of get a feeling for what's going on, and then you try conservative treatment, and some people are going to get better from that. And you're not going to need the imaging. I mean, and the other people are not, and you don't know what else is going on here, or is it worse than I think?
Yeah, and that's one thing, is like I'm not one to just rush out for MRI, barring red flags. Like there's definitely times where there's MRI like right away. But a lot of times with these overuse sports injuries, it's like, okay, let's go through a couple weeks of care. If it's like getting worse or not getting better at all, like then let's discuss that. And so, and having that ability to differentiate between the muscle and the bone is obviously very important as a runner. So that really encapsulates the first two topics that we wanted to discuss today. Which leads me to the third one, which is the lumbar disc issues that we deal with. A lot of times clinically, we have a lot of symptoms, and sometimes it's associated with sciatica, and sometimes it's not. There's a lot of different things that we look for on imaging with the disc, and again, this can happen to everybody, but I am seeing a lot of runners with it because a lot of our runners do tend to have a desk-sitting job also, or just anything else in their past medical history to potentially lead to that. So if you could, just like, we won't spend a ton of time on this, but I think there's like one of the biggest things that bothers me, and it's no one's fault per se in the general public, but there's a lack of understanding of the difference between a disc bulge, a disc herniation, the different aspects of disc herniations, and if you can just kind of, give us some info on
that. And it's in terms of the disc bulge versus herniation, it is a confusing topic, and I think not everyone uses the same nomenclature all the time, although there is some standardized nomenclature put out by our societies that we're supposed to do, but it can be a little bit confusing. And I think especially for the patient who has the pain can be confusing. So I mean, basically in terms of imaging for back pain, a lot of times people don't image anything right away. A lot of people have back pain, a lot of muscular pain related to the back. But usually a physician will start with just x-rays, because it'll sort of can show you degenerative changes, subluxations, things, compression fractures, things that you can tell right away, which is sort of the low cost, easiest to do study. But most of the time, a lot of these progress to MRI, where we can actually see the disc pathology, we can see edema in the bone, we can see a lot of the other findings. So, I mean, disc bulging, a lot of people have disc bulging, and inherently, it's not going to necessarily be associated with any focal pain unless it's, there's something related to nerve related. Disc protrusion or herniations are more like, we could more look at it like you have a toothpaste container and the toothpaste got squeezed out of the disc, and now it's going to go somewhere. It's a simplified version of it, but for the point here, and I guess where it goes and what it's hitting, what it's compressing, what it's contacting, sort of can lead to more understand where the pain is, whether it be one of the nerve roots, whether it be in the central canal. So those are kind of things that we look at. In addition, a lot of people have back pain from their facet joints in the back. That's a huge, and usually that's causing more focal back pain, where you can push on an area. Those are the joints behind the spine. Can get arthritis. They're very common. So that's sort of a different treatment. If you're having radicular pain down your legs, groin, lower back, that's more related to disc pathology.
Yeah, and that's what I see a lot is, and it's funny enough, I get a lot of patients that have, like you said, it's usually facet syndrome, or it's some kind of myofascial pain in the low back, or it's a disc bulge, and they get an MRI, and all of a sudden they associate their pain because they had a disc bulge to like a disc herniation, like they make that leap. And it's not obviously a lot of times.
No, I mean, many people have very asymptomatic disc bulges throughout their spine. Could have a spine, someone that has no pain at all might have been imaged and might have several findings on the thing that don't actually correlate to clinical things, at least before they knew about them.
Yeah, exactly.
As you said, but it's very important that the clinician who's examined you, really puts your symptoms together and your clinical exam findings with the imaging, because by itself,
it's huge.
Yeah,
and I think just to kind of wrap it up, like that's essentially the key. Is imaging is extremely helpful for us to finalize the clinical, symptom diagnosis, the whole plan of attack. But there's so much more that goes into it than just reading the MRI. It's matching up with the clinical symptoms.
Matching up with the clinical stuff, and we often get a very detailed clinical history from our technologists and from the clinicians, so we can try to put that together and be as helpful as possible. I think the good, one of the most important things about imaging, especially MRI in these cases, is not so much that it shows the bulge, but it shows what's not happening. And alleviates people's fear of something awful there, and it can rule out some of those conditions, which can then guide the rest of the path.
Which is kind of funny. I'll just end it here, but sometimes I get patients that come back with a very good, clean MRI, and they're almost disappointed because they wanted like an answer. It's like, no, this is good news that you don't have a disc herniation.
Yes, it is good news, but it can be disappointing when their pain is not explained by.
Exactly, they want an answer, and I understand that, but usually ruling out things definitely helps us get to that answer.
As a doctor, that's one of the most important things you can do is rule out anything that needs to be dealt with quickly or
absolutely
urgently.
So. Perfect. Well, thank you for your time.
Thank you very much for having me on here.
Really helpful. I really appreciate that, and then we'll maybe have you on again in the near future.
Sounds good.
Awesome.
Great. Thanks.